Local productions on QTV are made possible with support from viewers like you. Thank you.
Hello everyone, I'm Junia. This is Uncommon Sense. Thank you for joining us today. My guest today is Dr. Deborah Silkwood Sherer. Dr. Silkwood Sherer is an associate professor and the neurological curriculum coordinator for the doctoral program in physical therapy at Central Michigan University. She received her bachelor's in physical therapy from the University of Kentucky and earned her master's degree in rehabilitation administration from DePaul University. She completed her doctorate of health science degree in pediatric physical therapy from the Krannert School of Physical Therapy at the University of Indianapolis. Dr. Silkwood Sherer is also a board-certified hippotherapal clinical specialist. Welcome, Dr. Silkwood Sherer. I'm fascinated. What is hippotherapy?
Well, hippotherapy is just another treatment technique that physical therapists use, occupational therapists use, and speech-language pathologists use. So it's a treatment technique.
And what does it involve?
Well, basically it involves using the movement of the horse to work on therapy goals. So let's say I have a client who has a balance problem or something else. I'm writing goals for them, and I can treat them in the clinic, or I can maybe go out to a barn and we put them on a horse and we work on activities while they're on the horse.
Does someone hold the horse, or are there two or three of you on this?
There's a lot of us. Because I'm not teaching the patient to ride a horse. They actually are responding to the horse movement. So I have a horse leader, so someone guides the horse. And we usually have a couple sidewalkers. One of them might be me while I'm doing the treatment, because I'm doing other therapy techniques while they're on the horse. And I ask my leader to maybe make the horse walk a little faster, walk a little slower. And because of that, then the patient has to react to what's happening.
Oh, interesting. And what kind of reaction are you looking for?
Well, I am looking for a couple of things. I typically use it more to work on balance, but other people will use it for other activities. But what I find is people's core gets stronger. Like I might stop and start the horse and they have to react to that. So I speed up reactions to, like, being, say, if you're bumped in a store, you have to react to not fall down. So I'm trying to speed up those reactions so if they do get bumped in a store, they don't fall. I might be doing some things where we go around in circles. When I work with my younger clients, the children, we might actually sit backwards or sideways, and we may play catch with the ball while they're moving around on the horse. And at that point, I'm also working on them learning to maybe motor plan a little better.
Now, what does motor plan mean?
Well, basically your brain sort of says, I want to lift my arm up, and the body just automatically does that. It takes in sensation, it has this plan you've learned over time, and you're very quick at it. Some children, actually the brain processing doesn't work smoothly, and they have a hard time figuring out, well, how do I do this? And it looks very awkward, uncoordinated, those kind of things. And so what we're trying to do is make it look a little more coordinated.
Because they mentally imagine the next 2 or 3 steps in order to execute that movement.
Yes, exactly.
Oh, interesting.
And we all do that.
And when they're on the horse, is it mostly they're walking? Do you ever trot?
We do occasionally trot. It depends on what I want to do. We never go any faster than a trot.
Okay.
And typically it's a slow trot. And again, it's why am I trying to do it? Sometimes, if I have let's say a client who's really low tone, kind of sleepy, that trotting actually adds input to their joints and it helps wake them up. And they become more alert and pay more attention.
And is there a certain kind of horse that is trained to do this kind of thing, or that you lean towards a certain temperament?
Definitely temperament. I mean, a lot of people say, well, is it a certain breed? No, any horse will work if they have the temperament, and that's the issue. Horses are not very good at having that many people around them. So they have to tolerate that, you know, I've got someone on my back, and I've got someone leading me and I got 2 people beside me. And that's not what is a natural thing for them. And so any horse that we use has had a lot of training. We've done a lot of desensitizing. We've had them in an arena and we're tossing balls at them. I don't want, if I toss a ball and the client misses it and it hits the horse on the rump, I don't want the horse scooting off.
Yes.
So the horse has to be like whatever, and they don't care what's happening around them too much. And actually that's why in the team, the horse handler is very important, because their job is to watch the horse reaction. Because even we all have bad days and horses have bad days. And so I want to focus as a therapist on the client, and I want my horse handler to tell me if the horse is having maybe a bad day and maybe we need to not do that activity or those kind of things.
I understood that horses are very sensitive, and they understand the emotional and physical, information coming from the rider. But in this case, you have 4 people. So who is the horse relating to?
Hopefully the horse leader. Okay, they're paying attention to what the horse leader wants them to do. But they also will pay attention to that client and what's happening. We've actually had a couple of horses in the past who did this forever, and we had one horse that usually knew if a child was going to have a seizure and would kind of stop and warn us, and we'd stop, and sure enough there'd be a short seizure and then we could go on and do what we needed to do. So we've actually had some that are that sensitive. Not all of them are, but a lot of them are.
I find that interesting area of research. So how long is a session with a child on a horse?
It'll depend on what we're trying to do. Okay, if I've got a really young child who's really low tone and very weak, they may only tolerate 10 or 15 minutes. But then as they get stronger, we may go 45 minutes.
And how often would you do this?
Well, it's going to vary on the setting.
Okay.
For me, because I don't have, in my facility, there's some facilities that actually have therapy rooms right off the barn. So the therapist may do some traditional type of therapies and then go on the horse for 10 or 15 minutes and then come back and finish up. I don't have that, so my sessions tend to be once a week, and I try to do as much as I can while we're there. But I also may use the environment. We may walk on the uneven ground to reinforce the things we did on the horse.
Is this facility near Central Michigan?
Actually, it's not. The facility when I do work is in Dansville, Michigan, actually, which is down near the Lansing area. I have a good friend who I learned from who's an occupational therapist, and it's her business.
So your clients are mostly from the Danville area, or do they drive down for the extra work with the horse?
A lot of them will drive down. Most of the clients will be from around the Lansing, greater Lansing area. So, we have clients from Jackson that will drive up because Dansville is down close to Jackson as well. So clients will come from all over that area.
Oh, this must be a fruitful area of research.
It is.
As a technique to complement or perhaps replace other techniques?
It is, and that's actually what I do more now. I don't actually do a lot of clients because of teaching, so most of my work is usually the research piece. And we're trying to figure out why does it work. We kind of know, we've done enough research now, we know that children like with cerebral palsy contract muscles more orderly after they've done about 12 weeks of hippotherapy. We've got some motion analysis capture machines where we found that out. We've got studies that have shown us that their balance gets better. Now we don't know exactly why. And so that's kind of the next piece we're starting to look at.
Do they ever bond to the horse?
Oh, always.
Because I was thinking, well, maybe a machine can be devised at some point that simulates that. And then I was thinking, no, part of it is
the bonding, yes.
The relationship to the horse.
I teach, obviously, in a physical therapy program, and I do an elective class for my students, and I tell them that they can't have an ego because the children's going to learn the horse name before they ever learn your name. And they do. By the second session, they want to know where their horse is. And, if you have to switch horses out sometimes, they have a hard time. Because sometimes a child actually outgrows a horse. Type of movement that horse gives, I need something else now, and I might use a different horse who has a slightly different movement.
That's unusual. I wouldn't have thought the movements were that discreet.
Oh, they are. They're very, every horse moves just a little bit differently, and that's a part of, as a therapist, I also have to understand that aspect of the therapy. So when hippotherapy, we kind of look at it as when the horse moves, it actually moves the rider's pelvis. And it moves it in the same manner you would move your own pelvis when you walk. And so the body, then the trunk has to react to that, which is why I think we see clients learning to walk afterwards. But some horses will give you more of a, so I'm going to use my hand sort of as the what happens, but some horses will give you more of the pelvis doing this, some will give you more of this, some will give you more of this. And even at different speeds, they'll give you slightly different, how does that move? They give you all three motions, but they might give you more of one than another.
When you teach classes to physical therapists, or not you, but what is taught to physical therapists about their their bonding or non-bonding with their client? And we're talking about bonding with the horse. How about the client? How important is it for the client to really like or bond with the therapist of the day?
It's actually extremely important. There's actually some research that shows if therapists or patients, a lot of times, because we give them exercises to do at home, and a lot of times the reason patients follow up is because they don't want to disappoint their therapist. And so that bonding is kind of a nice thing. Particularly if you have clients who really just don't want to do those exercises, if you can get them to want to do it, and then get them eventually to realize it's really in their best interest. It's not for me, the therapist, but it does make a big difference. They have to trust you. And if they don't trust you, they're not going to do what you ask them to do.
How do you engender trust in someone in that particular situation?
For me, I do it by explaining everything I do. This is why I'm doing it. This is how I think it's going to work. Here's what I think is going to happen. And if it doesn't, I go, okay, obviously we missed something here. Let's try it this way. And, you know, I make them, they're part of the team. It took me a long time as a new grad to realize I can't fix people. All I can do is show them how to get better. I have to coach them. And so they're part of the team, and they have to make decisions, and I might have an idea, and if they don't want to do it, they're not going to do it. So then we go, okay, how would you like to get here? And so that's kind of, I think, how you do. You build a relationship, so it's a team kind of a thing.
Does that promote a sense of safety? I often think that when you go in for any kind of medical anything, that part of it is that comfort level or trust or whatever you're going to call it, that makes it a benign and also supportive environment, that you can relax into who you really are while you're learning the exercises.
Absolutely. And I think that's why, like with therapists, and I think probably occupational therapists and speech language pathologists as well, we spend more time with people than, like, say, the physician. The physician's very quick, in and out, here's what you need to do. You know, people are with us a minimum of probably 30 minutes. We're touching them, we're doing more things, and I think some of that trust also builds that way.
What's the effect of trust, of touching the body on a client?
It'll vary on the client and how much, I mean, there are some people who don't like to be touched, and so I have to explain to them, I need to do this to help you. I think that for me, I work mainly with people with neurological disorders, adults and children. And so my touching is to sort of cue them how I want their body to move and help them feel this is the movement we need for you to be able to do this yourself. And if they trust you, they let you do it.
So how did you get interested in hippotherapy as a technique to add to the standard palette of things you're taught in all the way up through graduate school?
Yeah, my youngest daughter has mild cerebral palsy, had always liked horses. And we actually started going to what I would call therapeutic riding, or from American Hippotherapy Association, we called adaptive riding program. And she started riding horses, and I'm watching her. And we really were doing it for fun. That was the whole purpose, and that really is what therapeutic riding is. It's a leisure activity. You are teaching the person to ride the horse. You adapt the equipment so they can be as independent as possible. And in that process, I met this OT who, at that time, was not an OT yet. She was a riding instructor, and she found out I was a therapist and started talking to me, and we started looking at how children move differently, and then that's where I actually learned about hippotherapy. I had not actually heard about it at that point. This would have been about 20 some odd years ago. And it was like, oh, that is really fascinating. That is actually happening. And so I started kind of playing with it, and I said, I am actually seeing some things happening quicker than I was getting in the clinic. So then it was, okay, why? And that's where I kind of got into the research piece.
And now, did your daughter continue with hippotherapy for a number of years, or is it a short-term treatment?
She actually did mainly riding. Hers was pretty mild, so we've done a few bouts of hippo with her over time when she had some issues. For the most part, she rides, and she's an independent rider. She actually competes in able-bodied shows with some compensations and loves it, and it's really good for her because it does help. There is a therapeutic benefit to the riding. It's just not therapy, and that's always the piece I want to get across to people. That if they're getting therapy, they need to make sure there is a therapist there.
Yes, subtle but true.
Yeah, and that's a medical model. Therapeutic riding is just that. It's therapeutic. I mean, when I ride, it's therapeutic.
Yes.
I take off. I do get some strength. I actually do a lot of my clients. It's short term. So hippotherapy should be like a therapy session. We're here for a bout of therapy. It needs to end. Okay, and that has been one of our problems, I think, as a association, the American Hippotherapy Association, is that we've had people that have kept people for a very long time. Now, having said that, very young children do get therapy for 5, 6, 7 years, clinic and non-clinic. So we'll do bits and pieces. A lot of times when I've decided my client has met the goals we set for them, the therapy goals, if they really still like the horse, then I try to refer them to a riding program because it's a great maintenance program for them.
Yeah, really.
And then hopefully if they have another growth spurt or a problem or something comes up, then they come back to me for another bout of therapy.
So what makes for a good mother, did you learn? When you said you noticed your child had a mild case, what did you learn from being a mother? How to do it well or better?
I'm not
we
sure.
all learn how to do it some way.
My comment about motherhood is it's probably the one thing that I'm a really good therapist. A mother I stumbled through. I had better instruction to become a therapist than a mother. And it's sort of I mean, I think a lot of people always said children don't come with an instruction book.
Yeah, really.
And they don't. So it was a lot of, one, I learned that I was not her therapist. I made sure somebody else treated her because I'm her mother, and that's
too much.
Exactly. I mean, I did follow up on home exercise programs and things like that, but her therapist, and so if I saw her doing something at home that I thought wasn't great, luckily I knew most of the therapists, so I'd call them up and say, okay, here's what she's doing at home. You might want to correct this when you see her again, that kind of thing, because if I correct her, it's not okay.
Yeah.
I think for me, my goal was to make her as independent as possible, and she is. You know, I guess as a mother, I guess I can brag. She just graduated with a degree in speech pathology, and she is now working.
That's a triumph.
It is.
That's a real success story.
Yes.
Now, had this been in your family, so that you had some exposure?
Well, actually, cerebral palsy is not a hereditary disease. It's usually some type of trauma, either in utero, during the birth process, or shortly after the birth process. So it's not necessarily genetic.
Thank you for teaching me that. I really, it's hard to know what, now that genes are, coming forward as an option to understand better, which we will in the next decade.
Well, and actually, that's sort of an interesting thing that you just said, because I am actually doing a multi-center study around the country, and we're doing the study on children with cerebral palsy, 3 to 6 years old, and we're comparing children. Some are getting hippotherapy and some are not. Okay, and we've had trouble recruiting enough children, and I think one of the reasons is because of the genetic component, we're better identifying children who probably 30 years ago were given the diagnosis of cerebral palsy because we really didn't know what happened. And now we have a much better way to say, oh no, this is actually this genetic disorder, even though it looks similar to CP.
That's a step.
It is, it is. I mean, treatment hasn't changed much, but I shouldn't say that. Treatment has changed a lot. We understand a whole lot more what's going on. But how I would treat that child, a child with a genetic disorder and CP, they may present very similarly in terms of problems that they have.
Yes.
That's what I meant by the treatment doesn't change.
You've been in the field a while now.
I have.
What's new in physical therapy? I mean, are we learning better? Are there better machines? Are there better exercises?
I think we're learning better exercises. I think we have a better handle on when to push and when not to push. We are seeing what I would call sicker patients with more comorbidities, more problems, particularly adults. In terms of machines, we've gone through machines, and we're finding, actually, I just heard an interesting comment from a therapist who works at Center for Medicine and Services, the CMS for the government. And her comment was that we found that doing the hands-on training people in home seems to work as well, if not better, than some of our fancy treadmills and some of those things. So from that perspective, I think the thing I've seen the biggest change is that children are getting services much earlier, and we're stopping some of the secondary problems that I saw when I first started practicing in the late 70s.
That might come forward because they were not attended to at an earlier time in the child's life.
Children weren't even diagnosed until they were maybe 5 or 6 years old, and now we're diagnosing them at 6, 7, 8 months, and so now we're treating them.
6 or 7 months?
Mm-hmm. We watch reflexes, and we may not know they have cerebral palsy, but we know they're delayed, and we go, let's start treating them now, and let's not wait till we see what happens.
Oh, that's really interesting.
Mm-hmm. Yeah.
So if a mother had a child and she's little, it would be through the pediatrician? How would this come about?
Well, a couple of ways. The pediatrician hopefully will catch it.
Right.
Sometimes they say wait and see. They're actually in the state of Michigan. We have an early on service program, and anybody can refer. So a mother can call the early intervention services in their county and say, I think my child has a problem, can you evaluate them? And therapists are around that will do that.
Oh, so interesting. There's always so much help around, but no one knows how to connect when you really need it sometimes, unless you know someone who's done it or is in the field already.
Well, I happen to actually have worked for the early intervention services at one time in my career. I've done a little bit of everything, so that's why I probably know about it. And Michigan's a little unique in that our early intervention services are done through our school system. So if you don't know the number, you could probably call the local school district and say, I have a child, who do I contact? And they can get you to the right place as well.
And what drew you to this kind of a field?
Physical therapy
Yes.
in general? Well, it's a good question. I was in high school, and I actually met a therapist. And in those days, nobody really knew what a therapist was.
Yeah, really.
When I was in college, I remember, you meet somebody when you first start college, and they go, what's your major? And I'd say physical therapy, and I'd get the, oh, you're going to be a nurse, or oh, you're going to be a PE teacher. Luckily, by the time I graduated, more people had seen a therapist at that point. But I met a therapist at a biology, chemistry club meeting, and she talked about it, and I went, because I had been thinking medicine.
Yeah.
And I go, oh, I really like that, because there's the physical activity, the exercise, you're with people more, you get to talk to them, and I really liked it. And I went to visit her one day, and just to see if I might like it, and I was going to be there for a couple hours, and I think about 6 hours later, she told me they were closing, and I had to go home.
Oh,
It was
that's
like
love.
Yeah, it was like, I like this,
How do you refresh yourself if you're or when you were seeing clients through the day? It seems like there's a lot of giving. I mean, high attention. No, you didn't.
Well, there's a lot of high attention, but I get a lot back, because when somebody accomplishes something, it's sort of that shared goal. Oh, we got it. You did it. You transferred by yourself today.
Such satisfaction.
Oh yeah, that's the way I see it. It's that, oh, you got better, and I got something out of it. I'm probably more frustrated on days where nobody made any gains. That kind of a day that was probably more frustrating to me.
Are they trained any differently now, the young therapists?
A little, in that we know more, so
Right.
the education's a little longer. It's now a doctorate program. So
Yes.
they have an undergrad degree, and they do 3 years of physical therapy school, well, 2.5 to 3, depending on the school they go to. And we do a lot more on testing. We have better test measures than we had when I was a student. We're starting to push function. Well, we always did function when I was a student. I think we're getting back to going function is important. We do have some new techniques that they are learning. But in general education, I don't know if it's changed tons. I don't know if it's a good thing or a bad thing. We've actually been having that conversation lately. Does it need to change more?
Yes, because I always wonder about repetition. Is this things you do every day, things you do once a week? I mean, you have to be pretty responsible, to take it and make it part of your life.
Well, and again, I would be bored if every day looked the same, but even every patient is different. They have different issues, different problems. Even as I tell my students, someone might have a stroke, the lesion might be in the same place of the brain, and the two people don't look anything alike. Because it'll depend on how severe the lesion was, it'll depend on the patient's motivation, body size changes, how you move.
Do you know, just to personalize the moment, if I do an exercise, whatever I decide to do, I have about a 6-week, 8-week tolerance for it, and then I don't like it at all. And I find I have to reformulate it. And I don't know if it's boredom or what, but
Totally agree with you. I do the same thing with exercise, my own personal exercise. I get bored. I've got to find something different to do.
yeah.
Or if I do something with a component of competition in it, then I'm a little better.
All right. Thank you so much. So a lot to learn today, and I would say the importance of bonding, whether it is with your horse, whether it is with your physical therapist. The relationship trumps everything. A good relationship. And there was a wonderful concept. You are really not a patient to a physical therapist. You are part of a team, and your feedback and execution are really important to the team. And we should all take that maybe in our medical and physical therapy if we need it attitude. There's also a curiosity of how could it be better, how could it be different, how could we really understand the patient. Is it machines? Is it something you could do at home just as well? Her comments about motherhood, non-measurable, and you sort of stumble through, you know, we all can relate to that. And also the children are different. One of the interesting things she said was horses are different day to day as well as within themselves. So be kind to yourself, because you are not the same every day. You know, some days you'll perform better, some days perhaps less. And I really think to get with a person who really cares any part of your life, you are ahead. So, as I always say at the end of every program, I would like you to go out and do something kind for someone you know and someone you don't know today and every day, this whole week and this whole month. Smile. People need it. People appreciate it. And I will see you back next time here with my next guest on Common Sense. Have a great week. Bye-bye.
To contact Junia, send her an email at info@juniadone.com. For more information, program schedules, and news about future guests, go to www.juniadone.com. Thanks for joining us. See you next time for Uncommon Sense with Junia Doan.
Local productions on QTV are made possible with support from viewers like you. Thank you.